Okay, shock. So here's the overview, page 274. This is chapter something. Okay. So it's a clinical syndrome that results from inadequate tissue perfusion. So there's an imbalance here between oxygen delivery and demand. One common thing they have, because there are 4 types of shock, one common thing they have is all of them have low blood pressure. And what's the significance of blood pressure? Why do we need blood pressure? To perfuse organs. Okay, so these patients have a mean arterial pressure of less than 65, so that they fall under the clinical syndrome of shock. Nobody comes in with a primary diagnosis of shock. Nobody. They will come in for something else and then they are diagnosed with shock. Okay, so let me illustrate. So what are the 3 elements of perfusion again? So since shock is a perfusion problem, there's an imbalance between oxygen delivery and demand because oxygen is delivered by blood, correct? And we need a minimum of 65 MAP in order to perfuse vital organs. So when this happens, when the MAP drops below 65, now we have anaerobic metabolism as a result. So the body continues, all the organs continue to work, but without oxygen, with less ATP. So let's look at the 3 elements of perfusion. They are the pump, the blood volume, and the blood vessels. In order for perfusion to be possible, there has to be an effective pump, meaning the heart must function normally. There has to be adequate blood volume, and there has to be competent blood vessels. When we say blood vessels, we are specifically referring to the arteries. Okay. So if the pump fails, it can fail directly or indirectly. Direct pump failure example is a heart attack, an arrhythmia. Say arrhythmia, there has to be some serious arrhythmia, let's say sinus tachycardia, supraventricular tachycardia, for instance, or ventricular tachycardia, something serious. Okay, or worse, could be VFib or pulseless VTAC, okay, something like that. So that is direct pump failure. Others are, let's say, massive aortic stenosis, for instance. Okay, so anything that will cause direct pump failure, meaning the fault is directly on the heart. The heart cannot function. Heart is essential in order to pump and circulate blood throughout the body. And the patient's heart failed. Okay, so we call it direct pump failure. This is classified as cardiogenic shock. So when you have someone dying from cardiac arrest, so yes, they'll put cardiac arrest as your cause of death on your death certificate. However, the technical cause is actually cardiogenic shock, meaning 0 blood pressure. Okay, you died from cardiogenic shock. But of course, what will appear on your death certificate is cardiac arrest. Now, there's also indirect pump failure. In indirect pump failure, the heart was perfectly fine. The heart did not cause the shock. However, something around the heart, particularly the lungs or the blood vessels around the heart, caused it to fail. Examples of this are trauma. You've heard of pneumothorax, correct? Particularly tension pneumothorax. That's an example. You remember cardiac tamponade? Okay, so that's another example. So in those instances, if you remember the pathophysiology or the nature of these 2 problems, the heart was fine, but The heart failed because of these problems. Now, in cardiac tamponade, what actually happened? It was the pericardium, correct? That filled with blood or fluid, causing congestion and drowning the heart, causing it to fail. All right, so we call it indirect pump failure because it wasn't really the heart's fault, but it still failed because of structures around it. In pneumothorax, the positive pressure, the patient lost negative pressure and there was a great positive pressure buildup in one or both lungs, moving the heart, shifting the mediastinum, okay, pushing the heart to the opposite side, squeezing it until it fails. Okay, so mechanical forces around the heart, or it could be also a tumor. We also have something called SVC syndrome. We'll talk about that later in cancer. It's one of the 6 oncologic emergencies. It can also cause the patient's heart to fail. Okay, so all of these collectively we will call obstructive shock. Electrolyte imbalance causing, well, that still leads to, well, no, it still leads to cardiac arrest though. So that is still cardiogenic shock. So this one will be called obstructive shock. Don't worry, we'll look at all the examples later when we get to the chapter. I'm just giving you an overview right now. So that's for pump failure. So we have the first 2 types are cardiogenic and obstructive shock. The third type is loss of blood or fluid volume. We call it hypovolemic shock. This is 1, 2, 3. Okay, hypovolemic shock. So there's a unlimited number of causes here. So you crap yourself to death. Okay, you have massive diarrhea, or let's say you bleed to death. All right. So massive. You remember diabetes insipidus, right? So we remember DKA. Okay, DKA, HHS. Those all lead to hypovolemic shock, right? Burns will also lead to hypovolemic shock. So unlimited number of causes. You could die from hypovolemic shock from an unlimited number of reasons. Now, the last type of shock is what we call distributive shock. Now, what is the automatic response when blood pressure drops? What's the patient's the body's reflex response? Sympathetic stimulation, right? Okay, so there's an automatic stimulation of the sympathetic response leading to increased heart rate and vasoconstriction. So in all of these examples, number 1, number 2, number 3, there is sympathetic stimulation there, right? So therefore, there is vasoconstriction. However, due to the nature of these 3, there are 3 distributive types of shock. Due to the nature of these, instead of vasoconstriction, there is actually vasodilation. So the nature here in distributive shock, which separates it from the other 3, is this one has vasodilation. It's different from the usual response by the body wherein the blood pressure drops, there's supposed to be vasoconstriction, correct? But here there is vasodilation, which leads to the low blood pressure. Number 1 example is anaphylactic shock. While there is sympathetic stimulation in anaphylactic shock, however, the nature, because what's the trigger for an anaphylactic shock? So this is considered as a severe hypersensitivity reaction, correct? You reacted to a dust, peanuts, okay? So a drug, for instance, a drug, food, or substance that you are highly hypersensitive to, and then caused a massive amount of histamines, correct? So you have an uncontrolled release of histamines. And what do these pro-inflammatory substances do to the blood vessels? Okay, they dilate, cause vasodilation. So you notice, what is the color of people who are in anaphylactic shock, are they pale or red? They're actually very red. Hey, it's strange because the blood pressure is so low, but then they are red because of the massive vasodilation that results. So the histamines here, the uncontrolled release of histamines as a reaction to the foods, drug, or substance that they are hypersensitive to, causes massive vasodilation. But there is still increased heart rate here because there is sympathetic stimulation. However, there is no vasodilation. In the second one, we call it neurogenic shock. This happens in spinal cord injury. Now, the cause of this is usually in injuries with T6 or higher, thoracic 6 injuries or higher, meaning from first cervical up to T5. They are at risk for neurogenic shock. Now, the problem here is because you severed the, let's say this is the brain, and this is the spinal cord. Okay. So let's say this is T6. Okay. This is C1. So the injury here causes a loss of sympathetic tone. What you have instead is parasympathetic. So if we have increased heart rate and vasoconstriction in sympathetic, because here now you have parasympathetic stimulation, what do you have? Heart rate will parasympathetic, rest and digest. So drops the heart rate, and of course the blood pressure drops because of vasodilation. So a little bit of trivia here. This is the only type of shock that has bradycardia. All other shocks will have tachycardia. Any questions so far? So this is the second distributive shock. And then the third is septic shock. So you've heard all the stories, 2020, all COVID patients. The story is usually the same. Patients got COVID, they develop pneumonia, they develop sepsis, they die from septic shock, right? It's not as simple as that. It's a painful way to die. Although at this point, the patient is unconscious, no awareness of what's happening to them, but it is painful. So the nature here is similar to anaphylactic, wherein there is massive vasodilation because of uncontrolled pro-inflammatory cytokines. So you can consider septic shock as a self-destructive response to something serious, meaning our body doesn't respond well when it's overwhelmed with an infection. We'll discuss in detail later the stages of shock because there's a different pattern in septic shock. It doesn't follow the rest of the other types of shock. The rest of the other types of shock follow a predictable pattern. This one is kind of strange, which gives septic shock a higher mortality compared to the rest because of the deceiving nature of how the stages unfold. Okay, so when it reaches the severe sepsis all the way on the way to septic shock stage, there is now massive vasodilation here due to capillary leak syndrome. Okay, so now all the capillaries, arteries, and veins dilate. There is massive loss of vasomotor tone, meaning there's no vascular resistance anymore. Everything are dilated, and the patient, of course, loses vascular resistance. So therefore, even if you have normal blood volume, there's simply not enough to fill the large blood vessels. Again, we'll look at the assessment and management separately. So these are your 4 types of shock. Okay, so that's the overall picture of the nature of shock. Okay, after this, we'll go into detail. Any question on the overview? All right, so let's go to the chapter now.
Oh, you said that's only shock that causes dilation.
Correct, the distributive shock. If I were also to rename it, I would actually not call it distributive, because what's really the purpose of sympathetic stimulation? Why does our body normally respond with sympathetic stimulation, which is vasoconstriction? Why do we do that? What is it trying to do? Where is the body trying to send the blood? Only to the central organs, right? It's actually a matter of a method of shunting blood, right? So your body's in danger, blood pressure drop, blood volume drops. So the body is trying to save itself by shunting. Yeah, let's put all the blood to the vital organs only. Screw the skin, the GI tract, the kidneys, send everything to the brain, heart, and the lungs. Okay, but in the distributive types of shock, the anaphylactic, the septic, and the neurogenic shock, that does not happen. Okay, so we call it really, it's not a distributive shock. So the proper name, in my opinion, should be maldistribution, right? Should really be called maldistributive shock, right? Because it's a faulty, it's a faulty response. Why would you do vasodilation, right? Should be vasoconstriction. Anyway, so shocks affects all body systems because, of course, all body systems need oxygen, depend on adequate blood pressure of mean arterial pressure of 65 or better. Now, the development depends on the type of shock. Obviously, anaphylactic shock, how does that develop? What is the evolution? Is it quick or really slow? It's pretty quick. Okay, you have a matter of seconds between after you administer an antibiotic, for instance, you see the reaction, boom, the patient could be dead in the next 2 minutes. Okay, so depends. Some shocks develop slowly, some evolve more quickly. Okay. As you know, again, the introduction, I started with the importance of oxygen, why our body needs oxygen. Of course, that's to make ATP, right? So without ATP, no cell can function. So we depend on a continuous supply of oxygen made possible by the 3 elements, mainly the pump, the heart, the blood vessels, and adequate blood volume. Okay, so here's the cytokines I mentioned earlier. So these are the substances that our body produces when blood pressure drops. Okay, so we have catecholamines, which are your epinephrine, norepinephrine. There's cortisol, your stress hormone, the sugar hormone. And we got glucagon, again, a emergency hormone to raise. So cortisol and glucagon are both emergency hormones released whenever these 5 triggers come: low blood volume, low blood pressure, low sugar, low sodium, and low oxygen. All right. So we already know vascular responses. They depend on the catecholamines to constrict. Okay, that's supposed to be the constriction. And we're familiar with the renin-angiotensin-aldosterone system as well, and how the kidneys respond to aldosterone. Okay. As I mentioned, most types of shock, except septic shock, follow a predictable pattern. So they have the same stages of shock. So all these stages of shock that we'll discuss now apply to all types of shock except septic shock. Okay, only septic shock. Even anaphylactic and neurogenic shock follow the same pattern, although because anaphylactic and neurogenic shock are technically emergencies, meaning they're a medical emergency, so they don't last very long. So we can't really observe the stages, unlike in other forms of shock, because anaphylactic shock and neurogenic shock, the patient's dead in under 5 minutes. So therefore, there's no time for us really to observe the progression of the stages, okay, unlike the other forms. Same thing also for cardiogenic shock. Okay, so it progresses pretty quick. So these are the stages. We've got 3: compensatory, progressive, and irreversible. Other textbooks add a 4th one, which is initial. I don't know why they put it as initial, because really the signs and symptoms are not attributable to, meaning you can't distinguish it. This is the initial stage. It's not really observable. I mean, that means some of us here will be in the initial stage every day. Okay, when you're hungry, you're already in the initial stage. Okay, so this author though only has 3, which are compensatory, progressive, and irreversible. Other textbooks also call the first stage as non-progressive. So I don't know which one the NCLEX will use. So just keep in mind, compensatory or non-progressive refer to the same thing. All right?
So,
Yes.
reason why sepsis, because, infections still circulating in the blood.
We'll get to that later, right? Yeah, because of the it's actually a weird response. Okay. Now, why is it necessary for us to know which stage of shock the patient is in? Well, it's crucial in order for us to implement certain strategies. Okay, so let's start with the first stage, which is the compensatory stage. The difference really between the 3 stages is the severity of the manifestations. Let's face it, if the blood pressure drops, blood volume drops, whatever, what is the automatic response again? Sympathetic nervous system stimulation. So therefore, what are the signs and symptoms going to be? Signs and symptoms of sympathetic stimulation. All right? Right. So the difference between the 3 stages is really the severity. So you go from compensatory to progressive to irreversible, the MAP changes. All right? Along with the severity of of course, there's pH changes because we go into lactic acidosis, correct? So expect lactate levels to rise. And of course, not only the MAP, but the lactate levels will, of course, the MAP drops and then the lactate levels rise, correct? And the pH will drop. Okay. So the severity differs for each stage. So basically the numbers, okay, let's say urine output also will steadily drop as the patient goes through the stages. So they're all from fight or flight. Okay, so I repeat, all the manifestations here because it's systemic response. So from the skin to the kidneys, to the bowel sounds, to the heart rate, blood pressure, labs, your BUN creatinine, your lactate levels, and your pH, again, change from one stage to the next. But as far as manifestations, we assess the same things. They just get more severe as we go through the stages. Okay. So let's start with the manifestations. There's a table which makes this easy. Are you appreciating tables and charts now?
Yes.
Alrighty, very good, children. Have you ever dreamed before coming to nursing school that you'll love a table and a chart?
Absolutely.
Okay, when you start working, actually, you will be making your own. Okay, so you'll discover that it's actually easier. Okay, so when you put data, for instance, you report to the doctor, you'll start making tables. Okay, here, doctor, here's the data. You look like a nerd now. So table 11-1. So here's the comparison between stages from compensatory or non-progressive to progressive and finally irreversible. Now, let me just give you a heads up. In irreversible stages, these patients don't really come back. Okay, when they hit the stage, I mean, it's not like we give up. We still treat them, but we know the prognosis. The patient's not going to survive. Okay, Charlie Sheen has come back from many scandals, correct?
Mhm.
These patients here can't come back. Okay, there's no coming back here. So really our chance is in the compensatory and progressive stages, meaning do we even want them to reach the progressive stage?
No.
Hopefully not. Okay, so but however, they will reach progressive stage, okay, whether we like it or not. However, we can still save them at the progressive stage. Our only hope is that they don't reach the irreversible, right? When that happens though, no, we don't wait until the patient dies. We give the families a heads up. Okay, the residents who are tasked with contacting the family when we see the parameters showing that they're already in the going toward the irreversible. So we start calling the family, talking about the prognosis and possibly changing the code status. Okay, because we give them a picture of what it looks like when we have to revive the patient. It's not really pretty. Okay, have you ever seen a code,
Yeah.
chest compressions, on an actual person?
Yes. Yeah.
Is it pretty?
No.
No, right? That's just the compressions, but the intubation, okay, and then how the patient reacts, okay, how the breathing that they do, okay, it's not pretty. Okay, so we describe that to the patients, especially when they're going into the irreversible. Then we give them the opinion, okay, what do you want to do, right? The residents will just share their experience with the patients. Depends also because this is grief, correct? So patients here, the families rather, are of course, what's the first stage of grief? It's always denial. So you can't expect them to say, okay, yeah, let's change to DNR. Of course, they will say,
No.
no, do everything, right?
Mhm.
Okay. All right. So here our parameters are starting from the blood pressure. So MAP, heart rate, respiratory rate, skin, urinary output, mental status, and the pH. Okay. So if you look at the numbers, like I said earlier, it just goes downhill. Okay, blood pressure drops, heart rate increases, respiratory rate also increases. In progressive stage, we really don't need to wait till the irreversible stage. We typically intubate at the progressive stage because we want to maximize oxygenation and to conserve the patient's energy. Remember, the patient's blood pressure is low. So do we want them to expend so much energy breathing? No. In order to do that, you have to intubate and then put them on a ventilator. Okay, so that takes oxygen demand and consumption considerably low. Okay, so we want to conserve whatever energy they have because again, is there oxygen here? No, this is a perfusion problem.
Yeah.
Blood pressure's not normal. Of course, there's no oxygen. Okay. So to achieve that, we have to intubate. Now, intubation and mechanical ventilation will be week 9, week 10. Okay, so that's a while away. The skin. Now, of course, what's the responsible for the cold and clammy extremities here? Vasoconstriction. Okay, so there's peripheral vasoconstriction, so therefore skin will suffer. There's no blood flow, so it'll look pale, cold, feel clammy. And as it gets worse, they looks mottling. Okay. And then jaundice. Now in irreversible stage, not mentioned here is there's really multi-organ failure already. Okay. So remember, we're talking about organ perfusion here.
Mhm.
So when they reach this stage, more than one organ has already failed. The first organ to fail typically are the kidneys.
Mhm.
Now, take note, this chapter 11 will only talk about shock, okay? Now, does this mean because the blood pressure is low that they'll go into AKI?
No.
Again, blood pressure is low, can they go into AKI? All right.
No.
So it's not discussed here. All right. Yeah, so they will go into pre-renal AKI. Are we clear?
Yeah.
Okay, and it's not discussed here. It's discussed in a different chapter. We did that last semester already. Okay, so the picture you're seeing here is just shock. We do have hyperkalemia, correct? Because what happens again when you have acidosis? There will be hyperkalemia. That's not mentioned here also. Are we clear?
Yeah.
All right, so the management here is simply for shock. Are we clear? And we're also not discussing the management for the underlying cause that led to the shock.
Because-
Clear? Well, this is the chapter 11. Again, let's say, for example, if you have burns that led to the shock, it's a separate chapter. All right, I just want you to be aware. All right, so don't compartmentalize, because remember, the NCLEX will be integrated. Are we clear? So let's say, for instance, we already finished AKI.
Yeah.
So we're not repeating it here. Plus, chapter 11 will not discuss AKI. That's already done. Do you see what I'm talking about?
Yeah.
Okay, so when you look at the patient in shock, there are multiple problems. Because remember, there's something led to the shock in the first place. And then because of the low blood pressure, the patient's kidneys will suffer. And then we have massive acidosis. That means you're gonna have to treat that. You're gonna run sodium bicarb at the same time. Okay, because the patient's pH here is really severe. You go 7 or below 7 pH. All right. So again, that's not discussed in chapter 11. Are we clear? Right. So these are really sick individuals, right? Urinary output, so decreased here, although still at least 30 ml per hour. Now, in shock patients, we really don't look at 30 ml per hour anymore because it's not really sufficient. So we look at it based on weight. So we now go with 0.5 ml per kilogram per hour. The ideal, of course, is 1 milligram, 1 ml per kilogram per hour, but we're happy with 0.5. Okay, so 0.5 to 1, let's just put it that way, 0.5 to 1 ml per kilogram per hour. Are we clear?
Yeah.
So that's our basis. Okay, so on the exam, when I give you scenarios on the next gen type questions, of course, you'll have the data. So you'll have the patient's weight, patient's output from hour to hour. So that'll be one of the tabs, right? You'll have an INO tab, for instance. Then you'll have laboratory tabs, again, from hour to hour. And then questions will follow. So I can either ask you what stage of shock is the patient in, right? Or what interventions are expected at this point. Are we clear?
Yeah.
All right. Because remember, next gen questions are going to be clinical decision based now. Okay, so you're expected to assess all these. So you click on certain tabs, report that to the physician. Okay. Mental status, of course, whenever oxygen levels drop, which organ suffers first? Okay, brain. Mental status changes or restlessness will be the earliest manifestations of hypoxemia. Then that will progress to lethargy. Patient now is not fully awake. Okay, they'll probably wake up if you shout at them or apply painful stimulus. They'll open their eyes. We've done Glasgow Coma Scale, right? We did. Okay. Okay. So there's lethargy, and then of course in irreversible stage, they're not awake at all. Because of the severe acidosis. The patient's already in severe brain anoxia, so of course no more consciousness. And acid-base balance initially, because of the sudden rise in respiratory rate, patients dyspneic because of the typical scenario really is, let's say it's sepsis, right? So patients in a nursing home, the nurses have not been aware that the patient is not their fault. Okay, old patients really present weird with pneumonia, unlike younger people where you can see, oh, you got coughing. These patients will just lay down. Plus, the older they are, then the weaker the cough reflex becomes, and they just have mental status change. That's the only manifestations they have. They'll just get groggy, stop eating. Then 3 days later, they get respiratory distress. So this is now what we're talking about. Okay, so they're now in respiratory alkalosis. So that's the compensatory stage already, meaning those 2 or 3 days they've been developing the sepsis, right? We're not aware, okay, that we didn't diagnose the pneumonia, okay? So we're just thinking, oh, he's just tired. But really, when that happens, you should really contact the physician, get an X-ray, okay, or get a urine sample, the possible common sources of an infection. Or it could be a pressure ulcer already getting infected. Who knows who last checked it or changed the dressing, right? So these are the common causes of death in the nursing home patients, right? So an infected wound, usually a pressure ulcer, pneumonia, or a UTI, right? And then this is how we see them now. The admitting complaint is respiratory distress. Why would that happen? Sepsis. And in progressive, the patient is now in metabolic acidosis. And as I mentioned earlier, the potassium here rises. Now, another factor that will contribute to the hyperkalemia is AKI. Because remember, right, once this blood pressure drops, patient goes into pre-renal AKI, right? And then the kidney, because there's oliguria, then there's also hyperkalemia, okay? So that's it. Any questions on the stages? Again, this apply to all types of shock except septic shock. Septic shock will have a different pattern. Yes, Mr. Lewis.
I think you're gonna get to that, but, last semester you mentioned that you're supposed to treat based off of, whatever the complications are. I forget the exact term, but like you wanna treat based on what you see, not. My question is, I'll wait for you to get to the next. I'm still a little confused.
Yeah, go ahead.
Fine.
Confused which part?
It's fine.
We're still on the assessment
Right.
stages.
That's why I'll just wait for you to get to the intervention.
Okay, so again, the manifestations of patients in shock depends. Which stage are they in? You follow? Okay. So there's no set signs and symptoms. It really depends. What stage is the patient in? Or in the ER, when they came into the ER, what stage are they in before they were brought in? Okay, medical management is really based on what type of shock are we talking about? Meaning, I'll give you a few options. Patient comes in, MAP is 63, oxygen saturation 82, respiratory rate 36, okay? Potassium 6. Do you know what type of shock it is? No idea. So therefore, what is our goal upon admission? What is your goal? What type of shock are we talking about here? Okay, what type of shock are we dealing with? Okay, so we'll do testing. All right. Now, what's the safest intervention you can give? A, oxygen. B, IV fluids. C, vasopressors. D, epinephrine. Safest one you can give for any patients presenting like that.
So air oxygen then circulate.
Yannick?
If you give fluid, you cause overload.
Oxygen.
Give the choices again. Give the choices.
A, oxygen. B, IV fluids. C, vasopressors like norepinephrine. D, epinephrine.
The option.
Oxygen will be safest. Can you give every type of shock
No,
IV fluids?
no, because you might cause overload. If it's a burn patient, you need to.
Look at the overview. Can you give everybody oxygen?
No. Yes. Oh, yeah.
Yes, everybody, oxygen's harmless here. Everybody can benefit from oxygen because blood pressure is low. Can you give everybody IV fluids?
No.
Which one specifically can be harmed by IV fluids?
The
Look at it here.
No, we can't see.
You can see on the board. The urine, because it could cause overload. Because they decrease urine.
Who will go into fluid overload?
Pardon?
Can go into fluid
I
overload.
don't know.
Now, which patient can go into fluid overload if you give them fluids?
Oh, it's not that one.
No,
It would be all of them,
ones.
it would be everybody.
The
other than
distributive.
except big ones.
The neurogenic one can go. The distributive people.
Think about it. If the distributive shock people have vasodilation,
Yeah.
wouldn't they benefit from
Yeah,
fluids?
the pump people.
So yeah, so they will actually benefit from fluids. If you fill these large blood vessels with fluids, it will increase blood pressure.
But the one with the pump, if the pump has a problem, it can't.
Well, anything can cause fluid overload, but initially we're talking about, initial intervention.
So the pump, if it's like the cardiogenic.
Okay, these guys, these two here may be harmed by fluids. Remember, what's the nature here? Did they lose fluids?
No, it's just
No.
that's not working.
Did they have vasodilation? No. So therefore, if you give these two people these two types of shock fluids, what could happen?
They could kill them faster.
You're increasing preload
Uh-huh.
and afterload. Okay, so you're making the cardiac workload worse. Okay, so be careful when you suspect cardiogenic or obstructive shock. We'll probably give fluids, but at maybe 30 ml per hour. Okay, just to make sure our lines are open. Okay, so first thing, of course, you give everybody oxygen and then start 2 large bore IVs. Okay, when we say large bore, what number? 20, 18, 16. How about hypovolemic shock? Yes, massive amounts of fluids. And these three. But we'll go through management for each one.
Yeah.
So let's go back here. So again, here, fluid replacement, yeah, depends on which type of shock. Oxygen for everybody. Then medication, we'll talk about emergency drugs shortly. Any questions so far?
No.
Okay. So monitoring perfusion, how do we calculate mean arterial pressure again? What's the formula? I kept talking about that. I forgot if you know. MAP equals
Systolic minus the diastolic.
Okay, so it's 2 times the diastolic blood pressure. Okay, let me write it.
One more time.
I'll write it. So MAP equals 2 times your diastolic blood pressure plus the systolic blood pressure divided by 3. Now this tells you, the formula tells you the importance of diastolic blood pressure, because really, when do the heart muscles perfuse? During systole or diastole?
Diastolic.
During diastole. The heart muscles do not perfuse during contraction. They only perfuse when they relax. So MAP tells you the value of the diastolic blood pressure. So 2 times your diastolic plus SBP divided by 3. You need, therefore, what's the minimum we need? 65. Okay. So from now on and further, I'll just give you a heads up. 90 over 60. Is that low, normal, or high?
Yeah, I remember that. It's normal.
Okay. What about 88 over 59?
No, just there.
Again, from now on, base it on 65. Calculate the MAP for this one. So 59 59 times 2 plus 88 divided by 3. So is that good or bad? It's actually good. Right? Depends really on the diastolic blood pressure. Yes, the systolic blood pressure looks bad, but is it really bad? No. All right. So don't go panicking when your patient's systolic blood pressure drops below 90. Okay, not all the time. Always calculate the MAP. Because you'll be fine. Okay, so your license will be okay. But of course, do we notify the resident?
Yeah.
Yes, of course you notify the resident, but don't go panicking, oh my God, or calling RRT. No, always base it on your MAP. MAP of 65 or better. 68 is way, way up there. If of course you monitor that patient, because we want our MAP. Do we want really our MAP to be at 65? No, you want to stay around 70, right? 75, that's perfect. All right. Should be at least at 70, but 65, yeah. Your patient is okay. Your patient's organs are perfusing. Let me put it that way. Yes. For which one? Again, 2 times diastolic blood pressure. So 2 times 59 plus 88 divided by 3. Any question on this?
55, that's the number you want to stay above.
Minimum, yeah, minimum 65. If the patient is at 65, organs are perfusing. But the moment it drops below, though, you better do something, right? You better do something heroic.
And
Okay.
in the rare world scenario, somebody's blood pressure is normally stalled as long as they're above 65.
65 or better. Their organs are perfusing. Okay. Yeah, and then you reassure the patients also, because the patients, family and the patient or the family, if the patient's conscious or the family's there, the patient's lethargic, you explain to them, okay? Plus as long as you have or if not, then do a manual calculation, right? But our blood pressure machines do have the map. Okay, so if you just scroll down, you just show them, okay, the map 65. No, they just explain to them the organs are perfusing. Okay. So you monitor that. Of course, you draw ABGs if needed. So as stated here, we'll discuss septic shock separately. It's a separate section because it follows a weird pattern. As I described earlier, most at risk are older adults, and the highest type of shock that occur in them is really septic shock. Okay, plus if you read this, I encourage you to read this chart. Most of them have heart conditions and are on beta blockers. So therefore, this masks the sympathetic response. So you may not see the tachycardia here, which makes the diagnosis and prognosis, quite poor for the elderly. And again, the temperature, they will not reach 101. Okay, so they may be at 99 and you don't know that they're already in sepsis. Okay, they already have pneumonia. And let's face it, the compensatory organs, the lungs, the heart, the kidneys, the adrenal glands, are they really normally functioning as you age? Not anymore. Again, based on the stages of shock. So when they're at the irreversible, I mean, there's really no coming back. Miracles happen. No, of course, we've seen people come back. We saw, I thought you were dead. Yeah, and then we see people still alive or even snap out of it. But those are very rare cases. Okay. So Keysen alert. Okay, by the time BP drops, damage has already been occurring at the cellular and tissue levels. So there's already organ injury there. We'll get to the individual, because this is in general speaking, fluids, oxygen, pain management. Let me just point out something. Okay, here, if the patient has low blood pressure, what's the position of the head of the bed? Remember, they have shortness of breath as well. So what's the head of the bed elevation here? You mean numbers? Okay, 30 degrees. If the blood pressure, the MAP is below 65, it should be 15 degrees. Okay. Because remember, there's shortness of breath, right? So you'll be tempted to raise the head of the bed. But take note, raising the head of the bed or putting them in a sitting position does what to the blood pressure? It drops it. All right, once the patient is in ICU, the doctors will put in an arterial line. This is necessary not only to monitor arterial blood pressure, real-time arterial blood pressure, but makes it easier for you to draw ABGs. So no need to keep sticking. You just attach a needle to the A line, and then there you go. You have arterial blood. Okay. So 30 to 45 degree angle. And then instead of raising the head of the bed, you raise the legs instead, right? What do we call that position again? Modified Trendelenburg. Okay, so let me illustrate in case you're not familiar. Okay, so this is Trendelenburg. That's trend. This is reverse Trendelenburg. And this is modified Trendelenburg. All right. So we use reverse trend if, let's say, you have a patient with, remember neurogenic shock? So that happens in spinal cord injury patients, right? So you may do this if necessary. If not, they'll be in trend. Okay. Because we need the spine aligned at all times. Okay, so here we go. Okay, that's modified trend. This are all part of your interventions. Of course, this is a life-threatening condition and the patient knows it. One of the manifestations not listed in the chart is sense of impending doom. Now, this is automatic when you have sympathetic stimulation. You have this, have you ever felt that? Like you feel like you're gonna die? You say you do that all the time?
No, I don't do that.
You're testing skills? No? So there is a sense of impending doom in these patients, especially when they're in the progressive and definitely in the irreversible stage. That is if they're still conscious. So we treat that, okay? And very important, like I said, we clarify because shock has a high mortality, especially septic shock. So we need to establish advanced directives. So first thing you clarify whenever you give report is the code status. What is this patient's code status that we were prepared? Now, don't think that, oh, they're DNR, so I won't worry. Just relax. No, that just means in case the worst happens, we don't have to call a code. But you treat them until they die. You call a doctor. Okay, you keep treating until the end comes. Okay. You're aware of MOLST, correct? This one says POLST, but for New York State, it is MOLST. That stands for medical order for life-sustaining treatment. Are you aware of this? I haven't showed it to you?
No.
Okay, so very easy.
DNR,
MOLST. Yeah.
imagine DNR, DNR.
You can put that on a MOLS. Okay, so it's a purple document. It's a bifold, therefore it's 4 pages long. It's very detailed. It tells you there are several sections. It tells you, okay, what do we, first page will say, if the, here, I don't know if you can read it here, if the heart stops, what do? Chest compressions or do not resuscitate. So you check one, right? If you make a mistake, that's okay. You trash this document and then pull another. Okay, because it's not like there's a number on this thing. Okay, it's not like a controlled um paper. Yeah. So you can grab any copy. And then as long of course we need signatures here from the physician and also from the patient or the patient's designee. So on this page here, we'll tell you who is the proxy or the decision maker. The patient's making the decision, meaning the patient was awake and aware when they filled this out. Okay, they did so. They signed it, and there's always a witness. The witness is usually not the physician because there's a conflict there. Okay, so usually the witness has to be another person and other than the physician. Okay, and then if it's verbal, because we can do this over the phone, then you need 2 witnesses. Okay, instead of 1. Then next page will detail, okay, what do you want for treatment? So you can specify, okay, I'll try antibiotics. I can do, vasopressors, or you can add also, okay, I don't want to be intubated, or maybe, okay, I'll try non-invasive. Okay, I'll do BiPAP. Okay, but I don't want any intubation. Or you can specify also, okay, we can do feeding, artificial nutrition, because remember, these patients stop eating, okay, when they're in shock. So you indicate also, do I consent to short term? So short term nutrition, they'll put in an NG2, long term, of course, PEG2, right? So this is complete. Everything you want done to you is on a MOLS form, right? Mhm. You get one. Family. Any other problem? Okay. Heads up also. I know we looked at a table, right? 11-1 for the comparing the manifestations, but you saw the chart, it was very skimpy. Now the details are in the paragraphs. Okay, so we've done the non-progressive or compensatory first. So now we're in the progressive stage. So here in the progressive stage, remember I said the body goes into a self-destructive response to something serious. Okay, so shock is a serious insult to the body. We're not very efficient. So instead of, yes, we have the sympathetic nervous system, which really doesn't help heart failure patient, right? I mean, the patient's already having a heart attack and then you're asking it to beat faster. So here, one of the self-destructive responses is because of the desperate release of histamines, pro-inflammatory cytokines, it causes a capillary leak, meaning the capillary walls have increased permeability right here. Because of the release of these, I'm on page 279. So because of the release of these massive amounts of cytokines, histamines, they cause increased capillary membrane permeability. Now, this can have disastrous consequences. Because the capillaries become leaky, how many capillaries are in the 100 million alveoli that we have? 100 million capillaries as well. So if each of those capillaries leak, what will happen to your lungs?
It's collapsing.
They'll fill with fluids. So now, how can gas exchange occur when your lungs are filled with water? Okay, so now this is what I'm talking about. This chapter will only talk about shock. What I'm talking about here, what can happen as a result of the increased capillary membrane permeability, is acute respiratory distress syndrome, ARDS, which is on a separate chapter. All right, so instead of the, on top of this, the patient is going into ARDS. And remember this term also, we talked about this in 241 when you were presenting on DIC. DIC also develops in this patient. This is all in the progressive stage. Okay, so we're dealing with all the drop in the MAP here. So the MAP is below 65 here. The acidosis is severe. There's hyperkalemia, and then there's also ARDS, and there's also DIC on top. So you still wonder why the prognosis or the mortality is high. That's why the mortality is high in shock. So do you really want the patient in shock? No, especially not in the progressive stage. Okay. Okay. So here, inflammatory response is activated. Now it will cause DIC. So there's now microscopic clotting, followed by exhaustion of all your clotting factors, platelets drop, and down INR, PTT increases, then you start bleeding. So as you read the table 11-1, refer here also. If I were you, I would create another table, add what you see here, because the numbers here are actually pretty specific. So here under respiratory, I mentioned ARDS. So here's your ARDS. We'll discuss ARDS in a separate chapter because there are other causes of acute lung injury. So ARDS results from acute lung injury. Shock is just one of the one of those that lead to acute lung injury. Okay, there are many others. Cardiovascular effects. Of course, this patient is now. Don't be alarmed here. Even though the patient doesn't have a cardiogenic shock, the troponin will rise here. Okay, we call that demand ischemia. That doesn't mean the patient's having a heart attack, but we monitor it anyway. But as long as the patient doesn't have any ST wave changes, okay, no changes in the QTC, nothing like that. The rise in troponin is simply because of demand ischemia, meaning there's just simply no blood flow, there's no oxygen flow to the myocardium. That's why some myocardial cells died and therefore caused a rise in troponin. But the troponin here is not crazy high. Normal troponin is less than 0.012, right? So the troponin here will probably be 0.0.2, okay, 0.07, or maybe 0.1 will be the highest you'll see. Okay, so not crazy like heart attack level troponins, but they will rise. Okay, so keep it in your mind that not all positive troponins are heart attacks. Okay, so it also could be demand ischemia from shock. Okay, so COVID patients had high troponins because COVID patients went into septic shock. Okay. Neurologic, again, all consequence of the metabolic acidosis. Remember, this is now progressive. Okay, so the mental status here, patient's lethargic, okay, not very responsive anymore. Kidneys, of course, the urine output starts to drop. If the patient here has severe hyperkalemia and we can't control it with medications, what are the ways again we drop potassium?
So much.
Don't say just insulin. There's a partner. Okay, insulin with dextrose. Okay, what type of insulin? Regular insulin IV with dextrose. Don't forget the dextrose. Okay, they should go together. What else? Calcium, gluconate. What else? Bicarbonate. What else? Yeah, the regular insulin with dextrose. Diuretics, or don't forget dialysis can also be done. Okay, so we can do short-term dialysis as well. Yes, SPS, or there's a new drug called patiromer. Patiromer. That's like the modern Kexley. Okay, the liver, again, that's why the bleeding time increases, because the liver, think of it really, all of these effects are, there's multi-organ failure here now. So starting with the lungs, the heart, the kidneys, the liver, they're failing. Okay. GI. So here there's already decreased peristalsis. Plus, what happens to the acid secretion here? Increases. Okay, whenever you have acidosis, there's also increased GI acids, and that causes peptic ulcers and now GI bleeding. And hematologic effects, the bone marrow here, are they still also perfusing? No. So what will happen to bone marrow activity? Okay, so there's also a drop in everything: anemia, thrombocytopenia, and neutropenia. Okay, so aside from treating the underlying cause of shock, meaning if this is septic shock, then there's antibiotics. If it's hypovolemic shock from, I don't know, diarrhea, bleeding, so we give blood transfusions or IV fluids. If this is, yes,
IV fluids, which one specifically, like normal saline?
depends, either LR or normal saline. So on top of the, when we say supporting the respiratory system, this means oxygen therapy. So whether you're using non-rebreather mask or BiPAP, or the last one would be intubation, IV fluids. When we say supporting pumping action of the heart, this is using vasopressors. Okay. And also when they're in ICU, then they'll have those intra-aortic, balloon pumps, those implants now. And if the patient's really like, already, and you're in a magnet hospital, which are capable, we can do ECMO, extracorporeal membrane oxygenation, meaning it's like dialysis. We oxygenate your blood using a machine. So we divert your circulation to a machine, which oxygenates it and then returns it back to you. But not all hospitals have that capability. Yes.
So the question that I had earlier, I think this is the answer, but last semester you were talking about for infection of the valve. You said
Endocarditis.
And in general, this was saying, asking us, you don't treat in general. We have to treat based on the symptoms, right?
No, that was only for two, which are sinus bradycardia and sinus tachycardia.
But in
Meaning,
general, you did mention that we don't just automatically treat like it's a dysrhythmic issue. We have to know the specific symptom that the person is having. Again, only for yeah. So, or let's say it was also true for first degree heart block and also for second degree type 1. Yeah, those did not require any intervention at all. Maybe just, I mean, not no intervention, but
identifying the underlying cause and eliminating it.
So, what we're going over now, those 4 bullets,
This is
So-
progressive.
this is for progressive.
Yeah, this is progressive stage now. This is quite serious now.
Right, but
If there's,
we're not gonna individually choose, one of the other.
correct, I see what you're saying.
Right.
So yes, that, not all of these will apply. I mean, if the patient doesn't need it, then yeah, so if the vasopressors aren't really required yet, so no. Because remember, vasopressors cause vasoconstriction, correct? So what does it really do to the workload of the heart? It actually increases it. So it depends. So the doctor has to be careful when to start vasopressors.
So even as being nurses, then if they're in a progressive state, we still
Mhm.
have to assess, find out, which intervention is necessary based
Mhm.
on the symptoms.
Yeah. Mhm. So most of these patients are in the ICU already when you have a progressive stage of shock. Some of them, let's say the patient is a DNR, which I hate because I mean DNR doesn't really mean anything, right? It doesn't mean you don't treat. But in my hospital, the medical ICU team has specific criteria, and DNR is one of them that they don't accept DNR patients in medical ICU. Well, we treat them, but on a different unit, on like I work in the telemetry, we keep them in telemetry. And they're still sick, but they don't, because of their code status, they don't qualify in ICU. Even if they're in, no, it's not, we're still treating them, actively treating them.
Oh, so you just won't do the intervention if they start declining? You won't call a rapid?
No, I mean, they don't stay in ICU. I mean, they still receive these. I mean, we still have, we have intubated patients, but when we run pressors, but they're just not in ICU. I don't know, but meaning the patient doesn't get the best care because I have 3 other patients. Whereas if that patient was in ICU, we'll have dedicated nurse. It's not palliative. No, we're treating the patient. We're actively treating, but just not the
Emergency.
It's a private hospital?
not yeah, private hospital. Not the, not the best care in my opinion.
What's the difference treatment they'll get in the ICU versus a general?
Again, a dedicated, no, less, because the care suffers, the quality suffers the more patients you have. Not because I have to attend to 3 other patients instead of, me focusing solely on you or just another patient. Okay, so let's say if I have 2 patients in ICU, I just go to, next door and then here. So I still, you still get really good care. But if it's now 4, I have 3 others, I can't neglect those 3. I know we never get 6.
Oh, so they'll leave them, so they'll leave that resuscitate critical patient on a med surg for the nurse that has.
Again, depends. That's hospital specific. Okay, I'm just sharing with you.
Right, so if they have resuscitate and we're giving them whatever doctor's orders there are, just.
Okay, again, don't get me wrong. The code status is simply if the patient is in cardiac arrest,
Right.
we don't. But doesn't mean we don't treat. We still have DNR patients that are in the ICU. Okay, depending on the yeah. The nursing home can't take care of acute patients. So when there's an acute problem, they have to go to the hospital. Yeah, because nursing homes can only do chronic. They'll manage your chronic problems, no problem. They're capable of that. But no acute. And now the nursing homes are even treating pneumonia now, as long as they have no sepsis symptoms. They treat them there because they can start IVs. They even have PICC lines. They even have central lines. Okay, let's finish up. So part of the therapy is always PPIs or H2 receptor blockers. We know obviously the patient is in a lot of stress, so high risk for peptic ulcer and GI bleeding. And on top of that, if whether or not the patient is diabetic, the glucose will rise. Okay, two reasons for this. One, cortisol is high. The other reason is what happens to the GI organ perfusion? Decreases. So what happens to pancreatic function? What happens to insulin production? What happens to glucose levels? Okay. So our goal here is less than 180. Okay, for shock patients, less than 180. Well, this is being realistic. Okay, because the blood sugar here will rise. Okay, whether or not this patient is diabetic because of the high levels of stress. Okay, because of the again pancreatic perfusion is decreased, so insulin production suffers here. Okay.
Like damage to organs also causing.
It's more like the cortisol and the again decreased insulin.
If the patient is non-diabetic, 180.
Regardless if they're diabetic or not, that is the goal, less than 180. Okay. And this is just again being realistic. Of course, we get it down to 100 or 95. Yeah, but that is the realistic goal. Okay, what less than 180. Because what will happen if the sugar is 180 or higher? What happens to perfusion? Again, decreases perfusion, makes your blood flow, especially in the capillaries, sludging. Okay, so very slow. So oxygen delivery suffers.
That's the cortisol is also increasing because of sympathetic response.
Right, again, yeah. So natural stress response is cortisol. So you notice your uniform shrink, right? Toward the 14th, yeah, 13th week. Yeah. Yeah, I don't know where they buy these things. So the less than 180 is based on evidence. Okay. And this applies to everybody. Cardiac, whichever patient. That's the goal. Less than 180. Yeah, everybody. Okay. And preventing complications again, like I said, these patients are already intubated, correct? So we'll discuss the complications related to intubation and mechanical ventilation separately. Because it's a long story. And we'll also talk about, because again, when you intubate somebody, there's complications related to that as well. Let's say a shock patient already has low blood pressure, correct? When you intubate them, there's something we call post-intubation hypotension. It occurs because how are we breathing right now? Negative or positive pressure? Negative pressure, correct? Meaning effortless. The diaphragm does everything. Air is sucked in passively. Now, if you turn to positive pressure ventilation, you're now pushing air into the patient's lung. You're forcing it under pressure. So what happens to intrathoracic pressure? What happens to the poor heart? It's squeezed, okay? Because you're now forcing air into the right and left lungs. They're squeezing the heart more. So what happens to venous return? What happens to cardiac output? So it drops the blood pressure some more. Okay, so now you have to deal with that as well on top of the shock. Yeah, but don't worry, we'll discuss all that when we get to intubation. Rest and comfort. So this patient, especially if intubated, we will have to keep them on propofol. Okay, so we keep them sedated. Again, the purpose of the sedation is, besides that, it's really to conserving energy, because blood pressure drops, there is very little oxygen, so ATP is hard to come by. Okay, so you need to rest the patient, rest the brain, rest the heart. Okay, irreversible stage, I won't talk too much here. This is again everything is, yeah, this patient is pre-departure. Okay, so here though, you start calling the OPO. So for New York, we have Live On. So they're in every hospital in New York State. So yeah, they have a number. So when they fall under irreversible stage, you call already. In fact, they monitor these because they have one staff in the hospital, meaning they maintain a small office in every hospital. And they monitor everybody. So especially if it's critical, so they'll call you when the patient is already in the progressive stage. So they'll start calling you. They'll ask, of course, they're polite, say, hey, are you busy? Can you talk to me? Okay. Then they'll ask about the patient. Okay, how's the patient? What's the code status? Okay, so because organs are precious. Okay, so they want to make sure. You'll think like, oh, this is a shock patient. What organs can you harvest? You'll be surprised. Okay, you'll be surprised. They can do something with these organs. So they'll call you. Okay, so don't be, don't brush them out. Busy. No, they're just doing their job. Okay? Yeah. They're what?
Is it like the thyroid? Is it similar to that?
I don't get the point.
Like,
What is this in relation to? The
No, I'm just saying, is it the same thing, like, because like, I'm just asking if this is. Like, in the OR, when you use X-ray, they have this thyroid shield.
uh-huh.
Like, every week they check to see how much X-ray you've been exposed to.
Not
Is it something like that?
necessary. Okay. So here the patient's MAP is tanking. This is now below 60. Okay, the MAP is in the 50s. This patient's gonna die. So if Live On New York, because sometimes, especially night shift, they're sleeping as well. They're supposed to be awake and because they're paid. If they're not, then you call. Okay, so you call. There's always an answering machine or answering service, and then once the person's awake, they'll call you back. Okay, but call them. Okay, because every possible expiration is a possible donor.
So
Right.
even if they're not under the.
Yeah, your job is just to call Live On New York. Okay, they'll take care of the rest. They'll talk to the family. Don't worry about whether or not the patient is organ donor or not. They'll take care of it. Hey, just let them know. Yeah, their experience, huh? Live On New York, yeah. In order to stay in business, yeah, they sell the organs.
So do they pay you?
Why do they pay you?
Huh?
This is not a this is not a third world black market thing. Okay, this is the organ donation network. Okay, so this is New York. You should go to jail. Are we clear about your job here?
Yes, sir.
Okay, so support the patient, support the family, especially because again, the patient here is already unconscious. So support the family, prepare them from grieving. Again, your number one job, call Live On New York. Yes, this is the routine. Yeah, call Live On New York. I mean, you're not saying, oh, this patient's gonna die. You just say that we have a candidate. Okay, and they'll take care of the rest. Okay? That's their job. That's their specialty. So they know what to do. Contact the family, or arrange everything. Okay, let's summarize the general management and then we'll finish the little bits after a break. So all types of shock and in all phases, against respiratory support, fluid replacement if appropriate. Again, caution with cardiogenic shock and with obstructive shock. Vasoactive medication, the most commonly used is norepinephrine, which is Levophed. Sometimes you'll get an order for epinephrine, but most of the time it's norepinephrine. And then nutritional support, please don't forget to feed your patient. Okay, so if the doctor, no, TPN typically is not indicated because the GI tract can still be used. So we prefer enteral.
Oh, to the.
Yeah, because you just change the, osmolarity, you cause fluid shifting when you use parenteral, TPN. We don't really do that. Okay, let's take a break. Come back at 12:45. Make it 12:46.
Oh, that's it. Still can't believe that.